This meeting is being recorded.
Thank you. All right. Um, it has serious consequences for the babies and leads to loss. It actually occurs a lot more often than people would realize. We've had two cases in the last couple of weeks that we've had to refer for suspected TTTS. About 10 to 15% of MODI twins or monochorionic gestations. It can also happen in MO twins. And what the cause is a vascular inequality of AV connections in the placenta. And it can have all identical twins share with MODI or MOMO placentation have some vascular connections. The key, what leads to TTTS is an imbalance in those AV connections, and it leads to one baby stealing blood from the other. Ultrasound findings typically start between 16 and 26 weeks. The earlier you see evidence of TTTS, generally the worse outcome. So what we suggest is screening every 2 weeks, starting at 16 weeks for any evidence. Now, it's important to know the chorionicity of the placenta to help identify patients at risk. And that's why last time we talked so much about identifying monochorionic diamnionic twins so that we would know those patients need to be referred for a higher level of care for screening for twin-twin transfusion. The treatment, if it is identified, in the past historically has been serial amnioreduction, taking fluid off the polyhydramnic twin on a regular basis in an attempt to increase the blood flow to the donor baby. But as of recent years, and I say recent years, recent decades now, laser ablation of those connections has been shown to be much superior than amnioreduction. And we typically will do amnioreductions only for those patients who either can't travel to have care at one of the centers that does the laser ablation, or they just prefer not to have the laser ablation. Next slide. So the key is that in the donor baby gives blood to the recipient, so it becomes anemic and very volume depleted. And that's the etiology of all the ills. It leads to decreased renal perfusion in that baby so that there's no urine production. You don't see a bladder on ultrasound. Baby's not making urine, it leads to oligohydramnios, and this baby is very growth restricted. Interestingly, most of the better outcomes are in the growth restricted baby. Now, the recipient baby becomes volume overloaded because of that blood that comes to that baby, and it leads to cardiac issues and cardiomyopathy in these babies. And generally, with that heart failure and the heart impairment, that's what leads to the worst outcomes in these recipient twins. Next slide. So again, 10 to 15% of MODI, MOMO twins will have TTTS. Too many AV anastomoses, too few artery-artery, venous-venous anastomoses to offset it. You don't have to know all about the Quintero staging, but this is how we decide where the patient falls in the scheme of whether they need to be referred for a higher level of care from us to see if these babies need to be treated with the laser ablation. And the bottom line is, if you reach Quintero stage 2, where you don't see the bladder in the donor twin, and whether the Dopplers are normal or not, that patient deserves referral to a higher level of care to consider laser ablation. So typically, if the bladder's not seen and it's TTTS and you watch the bladder, it doesn't fill, there's typically not very much fluid, if any, around that fetus. Next slide. So this is an ultrasound picture of two abdominal circumferences that you can see side by side, and visibly even a novice could tell that those babies are very different in size, with the left baby being the donor, very small belly, and the right baby being the recipient, the very large belly. And the next slide shows the discrepancy in the amniotic fluid. So you can see the recipient has a plethora of fluid on the left, and you can see at the edge of that picture a fetal part, and that's actually twin B, that if you notice is kind of stationary at the top of the uterus. How often do you see that on ultrasound? Generally, babies are moving around. You have to look very carefully, but the membrane is very closely applied to this twin, and it is in like a hammock and stuck to the anterior uterine wall because of the lack of fluid, and that baby just stuck against that wall. Next slide. So interestingly, with TTTS, not all cases get worse. So those patients that we find in stage 1 disease and we follow them, 70% will either remain stable or improve over time. So that's great news. And that's why we watch these patients very carefully weekly in the office once we suspect TTTS. Stage 2 or higher, that is, you don't see the bladder with or without umbilical artery Doppler abnormalities. At less than 26 weeks, it's recommended to refer for consideration of laser ablative therapy. If you do nothing in a patient with stage 2 or greater disease, the perinatal mortality is 80 to 100%. So those fetuses need some intervention. And I mentioned earlier, the earlier the diagnosis, the worse the prognosis. So if you diagnose TTTS at 16 weeks, it's much worse than when diagnosed at 26 weeks. And it can occur late. Typically, it occurs before 30 weeks, but I've seen it occur later. Obviously better when it occurs later. Next slide. There's a high rate of cord abnormalities in patients with, so let's switch gears just a little bit, because not all babies with discordance have TTTS. You can have selective growth restriction in patients with twins, and it happens in about 10 to 15% of modi twins, where one baby will be significantly smaller than the other. There's generally a higher rate of filamentous cord insertions or marginal cord insertions in the smaller baby. The key difference is that the fluid is normal in general around both of the baby sacs, and the Dopplers may be elevated, but they're typically not absent or reversed flow. Again, the prognosis is worse the earlier you see these things onset. And the prognosis is worse if the cord Dopplers are abnormal. But the key with selective growth restriction, where there's just a significant discordance, is expectant care, not referral for any other intervention. Next slide. The other is in TAPS, twin anemia polycythemia sequence, where it's much less common, and it occurs most often post laser treatment. So they laser ablate the AV malformations, and then over time, there are many smaller AV anastomoses, particularly in the periphery of the placenta, that begin to open up, and then slowly you see one baby stealing blood from the other. These, you do see the MCA Doppler differences, with the donor having a significantly increased MOM and recipient a very low. So generally people say you should see a 0.5 to 0.8 difference in the MOM between the donor and recipient. You can see a significant difference in the hemoglobin after delivery as well in these babies. The ultrasound shows normal amniotic fluid. And again, this occurs later than TTS typically does, and the abnormal MCAs generally suggest this. So again, most often after ablative therapy, we've had 2 cases of TAPS in the last 6 months that were not associated with TTS therapy, so it can be seen regardless. The outcome is good with these babies in general, and my belief is expectant management is the best approach. There have been studies where they have tried transfusion in the donor babies, but that increases the risk of complications, and the survival rate is very good. Next slide. So another thing that I always make sure that I do counseling my patients with twins, particularly monochorionic twins, has to do with death of a co-twin. We all know about vanishing twins, and it probably happens early in pregnancy much more than we realize. It's low maternal and fetal risk in dizygotic twins, but the potential for fetal demise in the remaining twin due to exsanguination in monochorionic twins is significant, and we believe it to be because of fetal hypotension in the co-twin with the death of the other twin. Next slide. And to just go over some numbers, I think these, you don't have to know specifically, but it tells the story. It paints the picture. With MODI placentation, demise of one twin, and this is after 14 weeks of gestation, 15% risk of demise of the other twin. Now with di-di placentation, where there's not that vascular connection, the risk is much lower, stated to be as high as 3%, but I think that's an overstatement. So 15% versus 3% risk to the other fetus. Now, with MODI placentation and death of one fetus with survival of the other, there's a significant risk in the surviving twin of having neurologic sequelae. Up to 18 to 26% risk of these babies having some significant long-term neurologic impact. With di-di placentation, that risk is extraordinarily low and really not increased. This neurologic risk can be seen and has been described with death of the co-twin as early as 13 weeks. And interestingly, the risk lessens after 34 weeks, but there's still that risk present throughout the pregnancy. Next slide. So delivery, about 80% of our twins deliver vaginally if they're vertex-vertex. Lots of studies have been done looking at outcomes comparing vaginal versus C-section. C-section does not offer any improved outcome if vertex-vertex presentation. There's a lot of controversy, and everybody does it a little bit differently with the vertex, non-vertex. I think the data is pretty clear that if the baby's weight is over 1,500 grams, a breech extraction is certainly a reasonable option for the second twin. Most of us would agree that if the twin A is non-vertex, that we will do a cesarean section for those babies. The theoretical risk of interlocking heads has always been stated since I was a medical student. Fortunately, I've never experienced that, and I think that that's probably an overstated risk, but very few people would intentionally deliver twins vaginally if A is non-vertex. Next slide. So again, with breech extraction of twin B, there's no increased risk of neonatal morbidity or mortality. There's actually decreased maternal morbidity compared to C-section, ECV, or vaginal vertex. Next slide. But I think the key is to make sure that it's done by people who feel comfortable doing it, right? So if you've never done a breech extraction on a second twin, I wouldn't expect you to try it for the first time by yourself. I don't think that that's a good idea, and the outcomes are different in experienced hands, no doubt about it. You have to have the ability to perform immediate cesarean section. We do all of our twin deliveries in the operating room with anesthesia on standby, as well as neonatology. Having adequate anesthesia for maneuvers that you have to do breech extractions is essential. I had the first failed breech extraction I've had in some time a few weeks ago, and a patient who couldn't have an epidural had a platelet abnormality, and her platelet count was 25,000, and she just would not tolerate the breech extraction. Unfortunately, we had to do a C-section, so it happens. You want to keep that fetal head flexed, not let it get extended. So the person on the mom's belly pushing down on the baby as you deliver that breech is one of the most important people in the room. And we generally say that if the estimated fetal weight is over 1,800 grams and they're over 32 weeks, those are the patients that we consider for breech extraction of the second twin. Next slide. So generally with die twins, and they're well dated, we will electively deliver those patients at 38 weeks. Frankly, it's not common to get to 38. Most of them either have developed an issue or gone into labor before that. So, but if elective, we do it at 38 weeks. Because of the risk of sudden unexplained death after 32 weeks, being as high as 5% in Mo-die twins, and given that neurologic potential complication with death of a co-twin, the counseling should be to the specific patient, let the patient help make the decision about timing. But we generally will have those patients delivered no later than 37 weeks, and depending on the comorbidities with the patient, at some point between 34 and 37 weeks for Mo-die twins. Next slide. So Mo twins, that is with a single sac twins, it accounts for less than 1% of all pregnancies. The concern is cord entanglement, because these babies are dancing around in there, and very early on they get the cords very entangled, and can lead as the babies get bigger to a higher risk of cord accident and cause of death for both of the fetuses. With current therapy and admission that we do for these patients, be curious to hear what others do, but we generally will offer admission in these patients between 24 and 26 weeks with daily fetal heart rate monitoring. And in more recent studies, the mortality has been as low as 7%, but there's still a significant risk to those babies. And we deliver these babies between 32 and 34 weeks gestation by cesarean section. Next slide. Lastly, and this is just a topic that I enjoy talking about. It's one of those things that we do infrequently, but we've had some real successes, and I think that very few people do it outside of centers like MUSC, Prisma Upstate, and here, where we have premature delivery of one twin before viability and consider retention of the other twin to allow maturation to enhance the likelihood of survival of that baby. Next slide. So this has been reported, and this is just one of the older studies in their case reports, and we've actually published a couple of case reports as well on this topic, but this was the largest that I am aware of, where they looked at 38 twins and 12 triplet pregnancies with the first delivery less than 25 weeks gestation. And after delivery of the first baby, they did high ligation of the umbilical cord as close to or inside the cervix as they could, trimmed the cord and the membranes, then copiously irrigated with chlorhexidine, and use tocolysis when necessary. Interestingly, a lot of these cases don't require tocolysis, but using tocolysis with either procardia, magnesium, indocin, whatever your drug of choice, treating the patient, in this case, with triple antibiotics and just close observation. Next slide. And in this particular group, 50% of the second twins were retained long enough to get to a gestational age where that twin survived. In triplets, they didn't fare as well, which makes sense. 2 of 14 of the triplets where they attempted survived for 14% incidence. Next slide. So the exclusions, obviously, if they have an infection or if they have an abruption, you're not going to be able to do this. This is primarily, I'll be curious to see if anybody else has tried, but because of the vascular connections and the thinness of the membrane, monochorionicity is not allowed to try this with. So if they're di placentation, we will try the asynchronous delivery. And obviously, if mom has some contraindication to trying to prolong the pregnancy, such as preeclampsia, then we would not try this procedure. Next slide. And I guess that's it. I'm not going to go into this. This is just some more stuff on monoamniotic twins, and happy to answer any questions you have about that. But I will stop with that. It will give us a little bit of time to answer